Support for the Think podcast comes from SMU Continuing and Professional Education, offering courses in art, literature, film, history, and languages, as well as professional certificates and test preparation. You can register online now for the upcoming fall programs at smu.edu/CAPE.
The TV commercials make it look like a snap.
If depression is taking so much out of you, ask your doctor about Pristique. Pristique is a prescription
Pop that
medicine.
pill, and in no time, you'll be back to playing with your kids or working in your garden or high-fiving at work. Those ads are required to disclose side effects, but they don't tell you that medication isn't necessary for every patient or every emotional problem. Some people are better candidates for talk therapy, but the healthcare industry has incentives to reduce the time and money it spends to help you get better. From KERA in Dallas, this is Think. I'm Chris Boyd. Dr. Enrico Gnaulati is a clinical psychologist and author. He's not opposed to the use of psychotropic medications for some patients, but he says the reliance on medicine and short-term treatments like cognitive behavioral therapy disregard the need of many people who could benefit from a true relationship with a mental health professional. His new book is called Saving Talk Therapy: How Health Insurers, Big Pharma, and Slanted Science Are Ruining Good Mental Health Care. Enrico, welcome to Think.
Thanks for inviting me on the show, Chris.
Why is traditional talk therapy harder to come by today than it was a generation ago?
For a variety of reasons. I think that beginning with the advent of Prozac, which was marketed as a safe and effective drug, primary care physicians now believed that they had it within their tool bag to adequately treat most mental health problems with drugs like Prozac. And so in a previous generation, if you broke down and cried about what was going on in your marriage or how you felt like you were failing as a parent or any other number of problems in living, you would get a referral to a psychotherapist. But that changed radically after the advent of Prozac. And these days, most primary care physicians and non-psychiatrist physicians see it as within their purview to prescribe medication for mental health problems.
What's interesting is the symptoms that you just described, feeling like your marriage isn't working right or you're a failure as a parent, that doesn't necessarily equate to mental illness. They're just problems that people have.
That's sort of a philosophical question, Chris. I mean, I think for most people, most mental health symptoms, if you look at the root causes, they're often existential concerns, feeling like you picked the wrong career, feeling like you love your daughter but don't really like her as a person, taboo thoughts, primal feelings like pride, envy, shame, lust, rage that you can't begin to know how to tap into and express. And I think with all the focus on medications in our culture and all the focus on short-term, quick-fix cognitive behavioral therapies, we've sort of lost the plot in terms of like what most people who cross the threshold into a therapist's office need and want.
You're a therapist yourself today, but you share that going to therapy was like psychological oxygen for you as a young man. How did it change your life?
Oh boy, I'll tell you a little anecdote. This is, it took me as a young man, the first time I entered therapy in my early 20s, it literally took me a year of therapy to decide that I wanted to continue in therapy, which may sound bizarre to listeners, but I was sort of suspect and didn't want to believe in it, and yet it was instrumental in me going from being a kind of an insecure, self-doubting, guilt-ridden young man who had trained to be a Catholic priest in rural Scotland and was full of neurosis. It transformed me over time into someone who has a solid sense of self, who's reasonably self-confident, who, doesn't avoid and deny my feelings, who has a good amount of expressive mastery of feelings, and all of these things. So what I got out of therapy is what I want most clients to get out of therapy.
There are lots of ways to do talk therapy. What you're talking about here is providing clients with, for one thing, a skilled, empathetic listener. Why is that humanistic approach so valuable to patients or clients?
It's foundational to really. So it's the confident expectation of empathy that really enables most clients to open up and to really bare their soul. So it's knowing that session in, session out, there will be a therapist sitting there facing you with a look of receptivity on his or her face, who looks like a benevolent, caring, thoughtful, discerning person who's there to really get to know you on your terms. And I think those are the conditions for most clients feeling enough of a desire to open up and to really delve into what's troubling them.
When you did want to be a Catholic priest, were the instincts to help people similar to the instincts that drove you to ultimately become a psychologist?
Oh dear, we're doing therapy on air now.
No, just asking a question.
I'm teasing. Absolutely. I mean, I think, and actually there are a fair number of therapists in the profession who started out, as clerics. Actually, my father-in-law, who was a Baptist minister for years, and during the 60s, ended up leaving the ministry and becoming a therapist. And I think that sense of mission, that sense of wanting to reduce human suffering, that sense of wanting to pursue a career where there's a higher purpose, absolutely, there's a lot of crossover.
So these days, as you mentioned, many patients who seek talk therapy are given cognitive behavioral therapy, which tends to be a pretty short-term thing. Can you explain how CBT works and what makes it different from the kind of therapy in which a patient really builds a relationship to the therapist?
That's a tough question to give a simple answer to, Chris. So unfortunately, I'm going to be guilty of making gross generalizations here. But there are really qualitative differences between what is called cognitive behavioral therapy and what are the more humanistic therapies, the more psychodynamic therapies. With cognitive behavioral therapy, it's really, and make no mistake about it, when with all the talk about evidence-based treatments, it really favors these kinds of approaches. And we're talking about short-term approaches. The typical length of treatment that's cognitive behavioral therapy is researched in, the time frame is like 12 sessions. There's workbooks involved, they're manualized, there's an air of productivity about it all. It's all about correcting problematic thinking, changing bad behavioral habits. And it's the therapist really functions more like a teacher or a coach than a wise, serene, discerning, careful, and caring listener. And it's seductive because who doesn't want tools? Who doesn't want to leave the therapist's office with something that they can kind of do on their own in their daily lives to lessen their pain and suffering? So there's a seductiveness about cognitive behavioral therapy, especially to Americans who are pride themselves on being rugged individuals and believe that they can will themselves to change. But I think it's illusory. I think that, frankly, most human suffering is caused not by faulty thinking, but with dreadful difficulty being able to tap into and acknowledge and gain expressive mastery of primal human emotions, like pride, shame, rage, lust, greed. Boy, I think I'm naming the 7 deadly sins there. But frankly, that's what good therapy is all about. And it is far harder, in my experience, to change, your routine ways of expressing emotion, acknowledging emotion, that is to change your thinking.
You're uncomfortable with cognitive behavioral therapy in part because it treats the whole process like a software update to eliminate bugs in our brains. It just doesn't sound very holistic.
That was me being snarky in the book. But you know what? I want to be more open-minded to, cognitive behavioral therapy. And frankly, I think cognitive behavioral therapy techniques are extremely helpful rolled into a broader humanistic therapy. Mm-hmm. So quite often with clients, I challenge their distorted beliefs. I mean, I like clients who will make sort of gross, overgeneralizing statements like, "I'll never find," my husband doesn't love me anymore. And you have data to challenge that, because the week before they just said they had a wonderful weekend away, and I'll point that out. So it's not like working humanistically doesn't include cognitive behavioral little interventions at times. It's just that the whole enterprise of cognitive behavioral therapy, as it's churned out by academics, and then the health insurance apparatus buys into it because it's got a lovely air of accountability and productivity. We can measure progress and change, and boy, the more we shorten the therapy, the more money we save. That's actually not true. We can get to that in a minute, but so it's that ethos though that takes over, and that the next generation of therapists are buying into, where they believe that the right thing to do is to offer these more scripted, abbreviated forms of therapy.
So is the kind of therapy that you practice, can it be measured quantitatively? Can someone sort of look at a patient's trajectory with you and write down definitively whether that patient has improved or not?
Wow, that is another actually philosophical question that's hard to answer. There's, when you start to measure progress and the things that really matter to clients, and frankly that really matter to people like me who practice in the field, you get into, like how clients will self-identify progress is that they want to be more capable of receiving and showing love. They want to be more self-assured, self-confident people. They want to be less emotionally reactive as parents or as husbands or wives. They want to be able to know what their true talents are and pursue those with enthusiasm. These are really the things that clients want out of psychotherapy, and that frankly make them symptomatic, the absence of all of that. So how do you measure that? How do you measure self-confidence? How do you measure self-assuredness? How do you measure a greater capacity to show and receive love? I think at the end of the day, we're sort of left trusting clients' own self-report in combination with therapists' perception and assessment of all of those, which is inherently kind of a subjective process, which academics don't like to hear, nor health insurance bureaucrats.
My guest is Dr. Enrico Gnaulati. He's a clinical psychologist and author of the book Saving Talk Therapy: How Health Insurers, Big Pharma, and Slanted Science Are Ruining Good Mental Health Care. You can join our conversation at 1-800-933-5372. You can email think@kera.org or leave us a message on Twitter. We are at KERA Think.
Support for the Think podcast comes from the SMU Doctor of Liberal Studies program, a customizable evening doctoral program where you can distinguish yourself personally and professionally. More at smu.edu/DLS.
This is Think. I'm Chris Boyd, speaking this hour with clinical psychologist Dr. Enrico Gnaulati, who joins us today from the studios of KPCC in Pasadena, California. We're talking about his book, Saving Talk Therapy: How Health Insurers, Big Pharma, and Slanted Science Are Ruining Good Mental Health Care. You can join us at 1-800-933-5372. So, Enrico, arguably Sigmund Freud was the father of talk therapy. Tell us about the most important and also the most problematic ideas that he promoted about how to care for people in emotional distress.
When you read the early Freud, like the first book that he wrote with Joseph Breuer, it's called Studies on Hysteria, which I did when I was writing the book and really read it carefully. He tells these wonderful clinical tales of how he really got clients to open up by, he was a self-confessed failure at hypnotizing. And so what he used to do was have them lie on the couch and massage their temples and instructed them to say whatever came into their mind, no matter how irrational, how alarming, how troubling, and giving them license and permission, especially during the Victorian era, to be able to, say the unsayable, think the unthinkable, feel the unfeelable. The early Freud, these are wonderful tales of emotional liberation. However, in the book, I say that the first person that talk therapy had to be saved from was Freud himself, because eventually he got into just sort of arcane notions that that neurosis was caused by people's, strange sexual fantasies that they just needed that he badgered them into admitting. And he really didn't take what they were saying at face value and work with just the content of what they were telling him, and show respect for their surface thoughts, feelings, and ideas. So but it was within the psychoanalytic tradition itself that the answers emerged. Someone by the name of Sándor Ferenczi, who was a Hungarian psychoanalyst, really reconfigured psychoanalytic practice into a more humanistic pursuit, where he truly listened to patients, truly believed in empathy, sustained empathy, and so on and so forth.
So I'll echo a question that you raise in the book, which is, how do we know when a psychoanalyst is wrong?
When he or she stubbornly digs his or her heels in, and after having made some interpretation that seems bizarre, and stands by it, even though the client is saying that just doesn't resonate, that doesn't speak to me, that's off base. So it's now, of course, classic Freudians would say, aha, that's proof that they're avoiding and denying because they don't want to admit the truth about themselves. But when you get good at it, you can differentiate between what is the client really denying, what's obvious that they're guilty of, versus when you've got it wrong and you just, you need to admit that and move on.
Therapy became a big thing in the United States as soldiers returned from World War II, which probably doesn't surprise anyone considering the trauma that they had experienced. What kind of help were they looking for, and how did their sort of entry into this field as patients change the way Americans thought about therapy?
There was a mass investment by the federal government in the training and education of legions of psychiatrists, psychologists, and clinical social workers after the war, because it was believed that one thing they discovered in signing up new recruits that many of them were broken individuals, and it was alarming to the powers that be that there were so many emotionally troubled individuals at an age where they could be conscripted into the military that just needed help. So there was that. There was the trauma of war itself, and then there was the need to help vast numbers of individuals returning from war to adapt to civilian life. And it was believed that the way to do all of that was to just massively fund mental health, which is what the federal government did. And so it made therapy cheap, affordable, easy to access in community mental health centers, on university campuses. And it was really the golden age of psychotherapy. You know, post-war America, therapy was very popular. And on up, really, until the late 1980s, when there was the confluence of the release of Prozac and then the entry into the marketplace of managed care.
Something I didn't know before reading your book was that until the 1970s, most psychologists worked in collaboration with psychiatrists. How did they practice in concert, and why did that change?
Well, I mean, back in those days, insurance companies didn't reimburse psychologists or clinical social workers directly. In fact, Medicare didn't. So there was a strange thing that needed to happen in order for mental health or therapists to get paid for their work. They had to really team up with psychiatrists, and they would be indirectly paid through them. I think the more psychologists and clinical social workers, and then later marriage and family therapists built their own professional organizations and engaged in advocacy with the federal government and got approval, through in order to get the treatment covered by Medicare. That then paved the way for insurance companies to do likewise.
The other change that you've noticed is in the way psychologists today are educated, so that what they learn now is all about science. Typically, that's the sort of thing that we embrace. If I have this right, though, you're not anti-science. You just think good therapists need to really understand their patients as human beings and not simply as collections of brain problems.
Which actually, the vast amount of science in the field buttresses and supports. See, that this is the thing I get into in my book. It's that we're told about evidence-based practice as strictly being the results of randomized controlled trial-type research, but that there is a wealth of research out there basically buttressing the fact that what makes for good, effective therapy is what we've believed for, decades, and that is things like empathy, the therapist's ability to build rapport, their genuineness, their authenticity in the way that they practice, their verbal acuity, their ability to kind of really use words to say the right thing in the right way at the right time to alter clients' feelings and perceptions about themselves. And the vast amount of research buttresses all of that. But ironically, and this dates back to my own training too, sadly, it was a little better when I was getting trained going back 30 years or so. But these days it's a lot worse, where I urge your listeners to go and see if there are any courses on how to show accurate empathy in graduate school, or how to acquire the interpersonal skills to perform, to embody great listening. So this kind of embodied knowledge, or what's called procedural knowledge, just does not get attended to in graduate school. In fact, being in your own personal therapy is frowned upon, even though for therapists, being in their own personal therapy is perhaps the single most important thing they can do to become a skilled therapist.
What do therapists look for when they're choosing a therapist for themselves?
Mm-hmm. You've read my book, Chris.
That's my job.
Actually, when you look at the research, cognitive behavioral therapists, when they want to be in their own personal therapy, they do not go into cognitive behavioral therapy in large numbers. What they want is the kind of therapy that I endorse in my book, which is a more humanistically, psychodynamically oriented form of therapy, which is ironic.
So I wonder if part of the problem here is that it's impossible to draw a bright line between the psychiatric conditions that most people would agree are the result of a chemical imbalance or a brain disorder and the kind of emotional and behavioral problems that a lot of us have that are a combination of our experience and maybe the ways we've learned to cope with things. You can't say this set of problems is physiological and this set of problems is emotional, right?
Correct, Chris. But, when you've worked in the profession as long as I have and in lots of different capacities, when I started out, I worked at a community mental health center in Seattle, Washington, where as a young man in my mid-20s, I was part of a crisis intervention team where I had to make next day appointments available. And so basically I did not know who was going to walk in the door. And 9 times out of 10, it was someone who was schizophrenic. It was someone who had bipolar disorder. It was chronically, acutely mentally ill individual. So I have that in my background all the way to the present where I'm in private practice and I, see mostly the well-heeled of society. So with the breadth of experience I have, over the years, you develop a kind of an intuitive sense between like what is true mental illness, what kind of feels like it's a brain disorder, strictly speaking, or mostly, versus what is some combination of having been born with problematic genes and one's biological makeup, but yet having life experiences that just aggravate matters, versus what are really existential type problems masquerading as mental illness.
You're listening to Think. I'm Chris Boyd. So I'm curious, when you have someone who has one of these diagnosable mental illnesses, like, you mentioned, people who suffer from schizophrenia, these days, sometimes they are given medication that might work to alleviate their symptoms. How often does someone say it's also really important that you talk with someone on a regular basis?
It's interesting because if you look at surveys, about 75 to 90% of Americans will say that they would prefer to talk to a professional about their problems versus take medications. Yet about 60 people will take medications without any psychotherapy. Now, the research shows that for real mental illness like chronic depression, for instance, it's really a combination of long-term in-depth psychotherapy in addition to taking medications that will get people on the right track. There's a terrific study out of London. It's called the TADS study, the Tavistock Adult Depression Study, that showed that about 44% of chronically depressed people, when they're given 18 months of in-depth psychoanalytically oriented psychotherapy, where they're really delving into their trauma and their pasts, their difficulty, avoiding, denying, repressing emotion, all that good stuff that psychoanalytically oriented therapists delve into. When given about 18 months of that type of therapy, 2 years after therapy was over, 44% of them were no longer chronically depressed versus 10% of those that had treatment as usual, which was meds only or short-term cognitive behavioral therapy. So, we can't be fooling ourselves. There are no shortcuts, even with people who have serious mental illness. There are no shortcuts. There are some who will swear by medications being the magic bullet, and actually sometimes that does happen. More often than not, it's mentally ill folks are muddling through with wraparound services, and that's meds, that's case management, that's ongoing psychotherapy. So there are no cheap, inexpensive shortcuts.
You point the finger specifically at Kaiser Permanente for setting this trend in motion, which is to say a lot of people with pretty serious problems are given medication and not necessarily prescribed talk therapy to go along with it or in its place.
That's correct. Sadly, I'm a big fan of Kaiser. I did my pre-doctoral internship there years ago. I have been a Kaiser member for, in excess of 25 years, had multiple knee surgeries there, so on and so forth. But, their model of care is a medical model of care. It's set up actually for clients to not develop a relationship with their therapists. It's not uncommon for Kaiser mental health to, have folks show up for a mental health appointment, and they're given like a group intake where they're filling out paperwork, and then they're told that they'll get a call. A few weeks passes, they get a call with a different individual. That individual then tells them that they're really not set up to provide long-term care, but to really address, to arrive at solutions fast, to be poised to kind of make referrals for medications. And it's really a kind of a fast food sort of approach to mental health, which is actually, it doesn't save money. I mean, if you really look at what's called the medical cost offset research, for every dollar spent on mental health, $4 is saved on avoidable health care, employee absenteeism, lost productivity, employee turnover. It's far cheaper to just set someone up with a skilled therapist and have them just settle into having regular appointments and let time pass, and they're less likely to go to the doctor over and over and get expensive MRIs or CAT scans or be, heading out to the ER because they think they're having a panic attack and so on and so forth. So it's really short-sighted, the Kaiser's model of care.
My guest is clinical psychologist Dr. Enrico Gnaulati. We're talking about his book, Saving Talk Therapy, How Health Insurers, Big Pharma, and Slanted Science Are Ruining Good Mental Health Care. You can join us at 1-800-933-5372.
Support for the Think podcast comes from the SMU Master of Liberal Studies program, a customizable evening master's program for working professionals. You can apply now for the fall of 2017. More at smu.edu/MLS.
This is Think. I'm Chris Boyd, speaking this hour with clinical psychologist Dr. Eric Gnaulati, author of Saving Talk Therapy, How Health Insurers, Big Pharma, and Slanted Science Are Ruining Good Mental Health Care. Enrico, of course, Americans love a quick fix. We always have. And I mean no disrespect with this question, but why does it take so long to yield results when you do what you do? Why does it take longer than we assume that cognitive behavioral therapy or a course of medication will take?
No offense taken, Chris. The easy answer to that question is because of the human condition. We want to believe that change happens easily and readily, and it's within our control to do that. But frankly, when you do what I do for a living every day of the week, you learn fast that for some people, for many people, changing their emotions, accessing their emotions, and changing their emotions is extraordinarily hard. It's we're looking at that. We're talking about the limbic brain here, I think it's just illusory and misguided to think that kind of change can happen fast and readily and it's within our control. I think most of us, when we get real and with ourselves, we realize that you just sort of muddle through life and you get better at it over time, and psychotherapy can help with that.
You mentioned that these days most of your clients are relatively well off financially, and that may be a factor of the lack of coverage. Many people get only a few sessions of therapy before their insurance cuts them off. The truth is it's expensive to see a therapist if it's not covered by insurance. How should people make decisions about when to invest their own money, especially given that a lot of people literally don't have the money to pay for the kind of treatment that you provide?
I mean, I can answer that question in a variety of ways, Chris, but it's a lot more expensive to go through an avoidable divorce. It's a lot more expensive to ruin your life with a drug habit. For good therapy where, with highly trained individuals who are good at what they do, who really, I have a presentation that I'm putting together that I'll be giving at a variety of conferences. It's called Disciplined Compassion, which is what I see has been instrumental to kind of the role of a good therapist. So for therapists who are kind of who enter the profession where it's like a vocation, whether they dedicate their lives to reading, pursuing, understanding, sitting with suffering individuals day in and day out, getting good at it and being vicariously traumatized by hearing just awful stories day in and day out, they deserve to be paid well. And on the one hand, and for many people, paying that can actually save them a lot of money in terms of just making misguided decisions about careers, about marriage. So, I want to hold the bar high there in terms of just that it's a worthwhile thing to pay for. There's that said, there's no reason why health insurance companies should be reimbursing therapists more. Right now, the reimbursement rates are about what a mid-level therapist charged in the 1980s.
Wow.
Psychotherapy is massively underfunded by health insurers. And so even just small increases in and there's cost shifting that goes on. So what ends up happening is that many skilled mental health professionals will refuse to take insurance because it's insulting how low they're paid by insurers. So then what ends up happening is as many clients looking for a therapist can't find someone on their plan. So then there's cost shifting that happens. They end up paying out of pocket. And because they pay out of pocket, the financial pressure is there to deny themselves and foreshorten needed mental health care.
All right, let's go to the phones now. First up, we have John calling from Dallas. Hi, John.
Hi, Chris. How are you this afternoon?
Very well, thanks.
Good. Glad to hear it. I just wanted to ask Enrico whether he was familiar with a Canadian novelist, Robertson Davies, because Davies has written a wonderful series of books in which Jungian analysis plays a big role. And in one of those novels, I can't remember which one, the analysand, the person who's come in for a therapy, says in response to one of the things the doctor said, but that's just common sense. And the analyst replies, well, what did you think therapy was? And that always seemed to me one of the best descriptions of what the long-term, in-depth analysis, whether it's Jungian, Freudian, or whatever, really ought to be.
What do you think, Enrico?
I was a spin-off reaction I had to that is, common sense, but good therapy helps people come to their senses in common sense ways. Yes. I'm having a distant memory of having read some of Robertson Davies' books back in the day, but I'm afraid that my memory is not serving me well in terms of what I took away from them.
We have a tweet here from Max who asks, what are the best ways to find a good psychotherapist, and how long should a person stick with a therapist when it doesn't seem to be working?
Great question. I mean, I think it's a very subjective process. I mean, frankly, it should be someone who listens more than they talk. I mean, I think that's like maybe a bizarre thing. It's actually not such a bizarre thing to say. So it's someone who's there, and they're truly invested in you, listening to you, really giving you ample time and space to just unpack your story, to voice your unvoiced feelings. And so so rather than someone who's sort of poised, active, has a laptop open, seem like they have an agenda, ready to kind of get moving, get going, where there's a sort of an unproductive level of productivity in the room.
How did you learn how to listen to people?
Okay, from my own long-term therapy over the years, and just how valuable that was. I'm actually not by nature, and I grew up in a big Italian Catholic family where everybody was talking over each other endlessly. So it's not in my nature to listen well. And if you interviewed my son, his eyes would roll if you said, "Wow, Enrico, a good listener." I'm good at it when I'm in role.
Mm-hmm. I guess it's also part of the benefit of asking a therapist to listen to us is that person's not necessarily invested in whatever it is we decide, right? Like if you're having a conversation with someone you care about, they're going to have an opinion about what you should do for yourself.
I think that's what people think about good therapists, that they're neutral, non-judgmental. They're there to kind of guard against their own emotions, to show appropriate sort of self-discipline, and really give clients all the airtime they need to arrive at their own conclusions, in their own way. I think that's largely true, but as anyone who reads my book will quickly discover, that no. Good therapists have opinions. Good therapists steer clients in certain ways, not necessarily based on their own personal agenda, but it's like giving parts of clients. I got to be careful here. I don't want to be too arcane. But when you really take the time to get to know clients, you really get to know what they want for themselves, which they avoid doing. So you may come on strong with a client to rescue them for themselves or to nudge them in the right direction. And that can involve coming across as a sort of an opinionated person at times. But when it's done well, you try to anchor yourself to just latent and dormant desires and dreams and aspirations of the client and to help them get out of their own way.
You're listening to Think. I'm Chris Boyd. Let's go back to the phones now. We have Chris calling from Keller. Hi, Chris.
Hi, thank you for having me on the show today.
Thanks.
I wanted to circle back around to what you were talking about before, I guess John called and asked his question. You described me perfectly to a T. I am not among the well-heeled people that you might see in your own practice. And quite frankly, I have come to the realization that I can't afford not to go to a good therapist. And so I cough up about $400 a month to go to my therapist out of pocket. Now, my question is, you told us earlier what we could do with what the insurance companies could do to solve the problem. But as far as a consumer on my end, what can we do to more easily afford that sort of thing, and what kind of solution does that lend itself to? I guess I'm asking.
Thanks for your call.
There's no reason why, Chris, you should be paying out of pocket like that. I mean, I think every insurance plan, frankly, with the parity laws in place, every insurance plan should have, mental health coverage, and psychotherapy should be reasonably reimbursed by them. So I'm sorry to hear that you're having to go in that direction. frankly, if for listeners out there who want good quality, affordable therapy, oftentimes a lot of training sites and clinics. I mean, good therapists have the requisite personality makeup. So don't be surprised if you go to like a clinic or a training center in your neighborhood or area where you live, where you shop around a little, meet with 1, 2, 3, 4 different therapists. You might get lucky and find someone who's just got the natural ability, and who's just where you can see someone for like a basic payment, and hang in there with that person as long as possible.
Some of the skills that you say we should look for and value in a therapist: warmth and tact and empathy and the ability to nudge people in the direction they need to go or want to go, sound like they have a lot in common with wisdom, right? And I'm wondering how, if you have a concern that new psychologists are being trained to look only at the science of this stuff, how do we train therapists who don't have a whole lot of experience, even life experience, to cultivate these qualities that their patients need?
That's a fantastic question, Chris, and it's a question that I keep coming back to myself over and over and over again. Unfortunately, most therapists these days, especially psychologists who come out of science-heavy educations, really have to de-educate themselves of what they were educated about to just sit there and be present to the suffering of another without feeling like they should be doing something or earning their fee or moving the client in the right direction. So it's as basic as that. And many of the new folks coming out of graduate school that I train, it's almost like they have to be deprogrammed in order to appreciate something as basic as empathy, like Rogerian empathy. Just sitting there trying to accurately attend to what's just below the surface emotionally with a client, and to be able to reiterate that and to say it back to a client in helpful ways. These sorts of basic skills, it takes early career professionals, they need to kind of de-educate themselves to show those kinds of skills. So I could get into my speech about what graduate schools should be teaching that they're not. But really attending to the question that you just asked, I think good therapists are throw themselves into life. They travel. They get in it. They break hearts. They have their heart broken. They know what it's like to be on the receiving end of exploitation, betrayal, deception. They're honest with themselves about having those same human tendencies within themselves. They read literature, they watch movies, they read philosophy, they watch movies about just everything that's troubling about the human condition. They expose themselves to the underbelly of life.
Dr. Enrico Gnaulati's book is called Saving Talk Therapy: How Health Insurers, Big Pharma, and Slanted Science Are Ruining Good Mental Health Care. Enrico, it's been a really interesting conversation. Thank you for making time for us.
It has been a privilege, Chris.
Think is produced by Stephen Becker. Shelley Canavy is technical director. Samantha Guzman is associate producer. Jeff Whittington is executive producer. I'm Chris Boyd. Thanks for listening. Have a great day.